I've already had plastic surgery. I'm super open about it. For the people who are coming in and talking about having a similar procedure, I'm absolutely 100% honest with them. I'm like, this was my personal experience.
You're like a walking now billboard for your own work. It's like, hey, like I've had this done. I know what it's like.
Now seeing you in higher K, I don't know if it's just the Moxie BBL Hero that you had.
Yeah, because this is the same camera as last time, dude. Dude, I got the full BBL Moxie, man. This is 10 days out, looking like I'm airbrushed, bro.
Yeah. Tell me about the experience. What was that like?
Well, it's awesome. Our lead esthetician, Allie, she does a lot of trainings. So this was like a Sciton training, and I get to be the demo patient, But, us as surgeons, we don't really get to do treatments often. We're usually doing treatments ourselves and other people, surgery. But yeah, so I was one of her demo patients. Allie's awesome. So she's training like 8 other estheticians. And dude, she's so fast. We did the new Heroic, so it has this intelligent control. So it gets this kind of like AI feedback, and so it's really fast. So literally the BBL portion of it was like a minute and a half. It's so fast.
Whoa, that's super fast.
And then the Moxie, does all the mends. It creates all those little epithelial kind of like almost like little scabs. That was the second part of it. And dude, those came off at about 3 days post, and I was just like glowing. I loved it, dude. And, we had numbing on for about 30 minutes because she did it. She went and treated my partner, Dr. Garlick's, like arms, like all of his freckles or all the sunspots. And then I came back. And so I was completely numb, dude. And she's doing the Moxie. I didn't feel a thing.
Wow.
That's actually super good experience. Have you done any of those before? Any of the microneedling, BBL, or the BBL Moxie, any of that kind of stuff?
Yeah, I've done just like standard microneedling, more like skin pen with like exosomes. I feel like that was nice. The only other things I've done kind of laser wise, I've done IPL because I had a couple of spots, and all of us, we're all on like crazy skincare stuff. And I still had a spot that was slowly working its way in. I actually did like a little reel on it, went over to the folks at Renuvian, just a couple of boops with the IPL.
Oh, nice.
I gotta say, no numbing, no anything. And it's like intense for a fraction of a second, then gone. Totally. You just a couple hits, and then it was slightly bruised for a couple days. And then literally the spot that I wanted treated is gone, like completely gone. It was wild. So I got to say, at least for my skin type, doing IPL treatments, maybe like a yearly thing just to keep it up, I feel like would be amazing just to keep off all the kind of like hyperpigmentation spots. Yeah. That's something I definitely get hooked on.
I'm like a Fitz 4, essentially, the way I tan. And with my Asian skin, they treat me at least a 4 or higher. So, but even with BBL Moxie, you can do it. Like you said, you got to be careful in some of these, obviously, with your skin tone, skin pigment. But yeah, it worked great. I wasn't worried. And she treats, Asian skin, African American, everything. It's really cool. These devices are amazing, dude.
Yeah. It's like, I'm a Fitz 2, so they can go nuts on me. There's nothing.
Just blast it.
Just put it to 11. Just go nuts.
The she went right around my eyes. That was awesome. Like literally, I really feel like it like airbrushes your face almost, Super cool.
I'll have to drop on by.
Yeah, always. Yeah, dude. We'll be in our building in 2 weeks. You got to come take a tour. Come hang out.
Yeah. Well, they've been saying that with us having this together, we should probably have maybe like a photo together.
Oh, I saw that.
It's like we haven't seen each other since before COVID. It was pre-COVID. It was the last time we actually like physically saw each other when we talk like every day.
Yeah.
Basically on the WhatsApp.
Totally.
But it's like I haven't seen you in like 5 years. I know.
I feel like I've seen you every day. But yeah, I haven't physically seen you. So this actually brings up something that I think we should talk about, is plastic surgeons themselves having treatments and surgery. I actually was interviewed about this recently, about this. So that's coming out in an article. But I wanted to get your thoughts on this. And like as a plastic surgeon, like do you feel like you should share that with your patients that you've had plastic surgery if you choose at all to have it? And if you did choose to have it and you told them, what would you have done, Sean?
I mean, I've already had plastic surgery myself.
There you go.
There you go. Yeah.
What would you have done?
I mean, yeah. So, and I'm super open about it. For the people who are coming in and talking about having a similar procedure, I'm absolutely 100% honest with them. I'm like, this was my personal experience. But for me, I had liposuction and Renuvian. I had like 360 lipo and Renuvian. And the reason behind it is when I left residency, I was like in the worst shape of my life, just like ate hot garbage for 6 years and like never worked out. So I was probably like 15, 20 pounds heavier than I am now. And then when I moved to Portland, I had like all the time in the world because I wasn't working for like 3 months, like waiting for things to go through. So I was like working out and eating right and lost all that weight, but I was in my late 30s. So then my skin was lax. I was like, sweet. Yeah. So excited for that. So while I was getting settled in practice, I was curious about Renuvian because I know that you had it and Dr. Moltz had it, and one of our other buddies. And I was like, well, does Renuvian work? And I feel like the best way to find out is like to be a guinea pig. So I packed up my bags. I flew down to Southern California and I had liposuction of my like abdomen and back and the flanks, like the love handles, and got hit with Renuvian as well to deal with some of those trouble areas and to deal with my lax skin. It was like super effective. Really, really loved it. I was a huge fan. So that's one of the reasons why I pushed to buy the machine for our group, because I tested it out. I'm like, it's good tech.
Yeah.
Living, breathing results, right? What else could you ask for?
That's awesome, dude. What was your recovery like? Because I'll talk about myself. What I want. I'm actually having something very similar done in August. So
yeah,
I'm cool to hear that from you. But
dude, we're doctors, right? Everything gets super accelerated.
Yeah.
We don't listen to our own advice or anybody else's advice. So for me, I flew down Thursday night. We had like dinner together, like out on Thursday night. I had
nothing
surgery
after midnight.
Yeah, it's like late dinner, like steak and red wine until midnight. Then straight to the surgery center. Had surgery on Friday. I took pain meds like Friday night into Saturday, and then we flew back on Sunday. And on Monday, I was operating
at work,
like full blown, full day of operating. I had my compression garment on underneath of everything, following doctor's orders, but Tylenol only, operating, and it was totally fine.
Yeah.
I mean, it wasn't a big deal. For me, the toughest part is the compression garments I was in, like a Designs Verani compression garment, and trying to operate in that and just getting hot.
Totally.
Just trying to find out what was going to work for me was the biggest thing overall. But pain wise, really just pain meds for like 36 hours and then just Tylenol, ibuprofen. After that, it was fairly easy recovery.
That's awesome. Yeah, that's honestly, you bring up a trouble there. I think it's like you, me, and a lot of guys our age, right? Like we don't talk about it a ton. And I have a lot of male patients who come in, we do the exact same thing. It's a 360 trunk, chest, lipo, skin tightening, because we need that as well. Skin contraction with Renuvian. Secondary skin tightening. But that's what I'm having done in August. So my partner is going to be doing that. And I'm very open about that, and that's my question is like, I don't know as surgeons if we have to share it, right? Like we don't have to. But I feel like having gone through at least some aspect of what patients go through in terms of the prep, like you said, the recovery, going through all that, I think you definitely can relate to patients. But like you said, you're like a walking now billboard for your own work. It's like, hey, like I've had this done. I know what it's like. This is what I experienced, because I'm like, hey, right now it's like, well, I know all my patients, they tell me this, and I can kind of convey that to a new patient. But I'm looking forward to it. Like I said, I've gotten to my goal weight, been working on doing things too, and it's just like this stubborn area, It's like I look at my relatives, we all have the same inner tube thing going on. I just can't, it's stuck, Oh
yeah. And the love handle area, I mean, if out of all the stuff that, all the area that Dr. Moltz treated, if it was just the love handles, I would have put up the same amount of money.
Yeah.
It is worth every penny because it's just completely 100% gone.
Amazing.
And then even with some fluctuations in weight, it's just the waist is so much smaller. So pants fit different, shirts fit different. It's just, no question.
That's awesome.
But with my patients, I'm absolutely a sharer of all that. I mean, whatever I can use in my arsenal to like discuss that situation, I'm an open book for that kind of stuff. I'm definitely an oversharer.
Well, I think like in today, like we look at social media, a lot of the posts that we do, it's our patients are talking about their surgeries. They're tagging us as their surgeons. They're sharing with other people. And like, I don't think there's any moral obligation for anyone to do that. Maybe some people do it for their own reasons, right? Like maybe it helps build their following, or maybe they're just doing it because they want to be informative, or all the above. But I think as surgeons, I think we are in that similar category. Like in a lot of ways, you and I are influencers of patients. And so I think understanding the process, going through that ourselves, not required, but I think definitely can help our patients.
Yeah. I mean, in our office, one of our staff, they had liposuction and removing of the neck. And anytime somebody's coming in for that, they end up talking with her just to figure out what her experience was. And they're like, the most helpful thing of everything that I had nothing to do with you. It had everything to do with your staff member who had that done. Because they're like, you could tell me exactly what it felt like, exactly what the recovery was like. I'm like, yeah, I mean, it's fair. Firsthand knowledge, it just makes sense.
Okay, so along these lines, actually another thought about this. So now you talk about your staff, right? Staff getting surgery. Like, is that common in your practice? And like, are surgeons operating on your own staff? And does that become, like, are they willing to share that? Is there a requirement in your office? Because I've heard different things from other practices. We have our own kind of policies, but what do you guys do in your practice?
Yeah, I mean, it's certainly not a requirement for us. It's if somebody is, when you're working in that industry, right? It's like you see all these things happening. You're like, well, I want that. That looks great. I would also like that. So we have it set up where we have discounts if somebody who's working there wants to have something done and they can enjoy that. And honestly, I don't operate on a lot of people who are currently in the office. It's after they move on to like another position. Cause like MAs and front desk staff, they're all, you're a stop off on their way, their journey to whatever they're doing, medical school, nursing, whatever they're going to do. But after they leave is when they come back. They're like, okay, now it's time for the breast talk. Now it's time for a lift. Now it's time for the tummy tuck. So we see a lot of that. I was actually kind of surprised by that. And it's, it's intimidating because you know them very closely. You're like, oh my God, it's like, this is what I do for a living, but you only want you want the best for everybody, but totally. You know them so personally. Yeah. You're like, thank you so much for the trust, but it's lightly terrifying. Yeah. Thankfully, it's like things go well. They're excited and happy. Yeah.
Yeah. We kind of have both. We have patients, obviously, that are our staff that still work there, but then, like you said, others that have left and then come back. Actually, someone today I saw was a similar situation, has moved on or, gone on other things in life, but it's cool to see them again. And yeah, I agree. I think, to require any patient, whether that's staff or, some surgeons now are trading surgery with influencers so that they advertise them, on social media. And I don't, the ethics of that, I don't know. It seems a little off to me, but we could talk about that later. Yeah, I agree. But so there's that as well, right? So to ever require or make someone talk about the surgery you did, and because what if they're like not happy with it? You do everything and they're like happy, but now they like have to act like they're happy, if they're really not, and just because you gave them a discount, there's like all these things around it when it comes to that. But I think staff, like they are, like you said, they're like one of your best, like I think sellers of your work though, because they'll be honest to patients and they'll be like, hey, I had one of our coordinators, she had a blepharoplasty done and she like raved about it, and people can see it. They can tell she looks good and she's happy with it. So I think there's just benefit in that. But again, I think the line of like making people do it is, and I know people have done that. So
yeah, I think another one who it's a good type of patient to have. It's like nurses within surgery centers and hospitals. It's like they see everybody's work.
Yes.
So if they see everybody's work and they choose you, you're like, okay, well, then you're really trusting me to do this for you. They will just rant and rave to like all the other nurses. And then you see like one nurse from one hospital. And then I see like 3 nurses from the same hospital. They're obviously like standing around the nurses station kind of talking about things. So it's always good when you see nurses come in. You're like, okay, I'm doing something right.
For sure. Yeah, that's awesome, dude. I think, like you said, of all people, they see all the surgeons, they're going to sit and compare and look and see how the patients, I think a big thing are recovery nurses. So not only just because circulating nurses help in the OR, they can see while you're doing the case, they can see how your cases progress, if you're struggling, all that stuff. But the recovery nurse,
and on-table results.
Yeah. They totally. Yeah. And then, and then the recovery nurses though, they're like seeing these patients waking up from surgery. They're, they're inspecting things, like I said, kind of pretty much on table. But also like their pain afterwards, and because they'll see differences in pain even immediately post-op in different surgeons. And that's interesting to me that they can notice that, you know? So, I mean, I don't know. Like, I never really thought like you could have that level of difference. Like, let's say I do a tummy tuck, you do a tummy tuck, another surgeon, like different levels of pain from the same surgery.
Absolutely.
Right?
Oh my God. Yeah. I know it's unbelievable.
Yeah.
Yeah. I remember in residency, you'd have some surgeons, you look at their post-op patients and they'd be like heavily narked up for weeks. They said they couldn't move for the first 3 days. And then you have other people who are up and about and it wasn't a big deal.
Yeah.
And a lot of that just comes from using the right local and doing it the way that it kind of should be done.
Totally. And I think even, you know, there's a lot of really good information out there and data about, you know, prepping patients even before they have the surgery, you know, the ERS protocols and things to really get patients prepped in terms of pain control and management. So even starting medications before they have surgery, you know, that morning or whatever it is before. I think those things are all super beneficial. And I think overall, like, you know, this is like a guest experience in a way. They're patients, but it's like when you go to Disneyland, you know, it's like the minute you walk in the park, even before that, but the minute you buy your ticket, right? Like that, just that experience. Then when you get to the park and then when you're in the park, it's all an experience you have. And I think for patients, it's very similar, you know, from the minute they meet you to their pre-op to the day they show up at the surgery center, surgery and after, it's just this experience. And I think it's a summation of all those things that then they're gonna be like, hey, that was a good experience. I'm gonna refer them, you know?
Yeah. It's not just the surgery. There's so much that goes into it. You're right about that. That actually leads me to something I want to talk about. I want to talk about Exparel. It's like, are you a user of Exparel for your tummies?
I literally, the only tummy tucks I've done in the last 6 years without Exparel were at the hospital where they took the privileges away where we can't inject it anymore. And I've like we've called the head pharmacist of this particular hospital chain because of it. We're trying to say, hey, here's actual data in plastic surgery show that it actually is effective, but they only let the orthopedic surgeons use it currently. So the only patients I've done tummy tucks on without it were those patients. And there's only been a few of those. I love Exparel. I've been using it since I started practice in 2018. And I really, really think it makes a huge difference.
Absolutely. Yeah. And I think the added benefit of not having to do an on-cue pump where you have like extra catheters, like you already have drains, you already have things that you're going to deal with. You don't want to have like extra tubing and then like a bandolier with like a grenade full of local anesthetic that will slowly drip in over days. It's like just a quick shot is nice. Yeah. I think even our hospital patients, we have access to Exparel. Awesome. I think all the hospitals, like they supposedly it's supposed to be only for colorectal or whatever, but when we ask for it, the nurses
that's awesome.
Give it to
Maybe
us.
Maybe I'll just try it next time.
I'll just get it. Just put it in my hand.
Just give it to me. I'll take the blame. I mean, so I've done like Marcaine. You know, I was like, well, at least give me, you know, bupivacaine or something, and I'll do that. And there's a difference for sure, because it only lasts for, even if it's in there for 8 hours or so, you know. And you see the next morning. Like actually, this happened. Prime example. I did a hospital case on a patient yesterday from out of state. We did the hospital because they had some medical things, so I wanted to monitor overnight. So it's purely cosmetic. Did a tummy tuck, breast lift, fat grafting, 360 lipo. And I did the Marcaine because they wouldn't let me do the Exparel. And I went and saw her today. And I mean, yeah, everything looked great. But she's like, yeah, I'm just really uncomfortable in my abdomen, you know? And I was like, well, I did give you the Marcaine, but it only lasts 8 hours. I'm sorry, you know? And I don't want to say, well, it's normally 3 days, you know? But what do you do? I mean, you try, obviously, I think you and it's always like looking at what's the best things we can offer for our patients, right? I think some people have the mentality of like, I'm going to not cut corners. I'm going to save costs as much as possible so that I maximize my own gain out of this case, right? Or I think other people have mentality. You and I are very similar. It's like, how can the patient have the best experience? And even if that means that obviously you and I are taking home less to our practice, it's more about the patient experience, you know?
Yeah. Yeah, I mean, for the surgery centers I go to, they do not provide it to us for free. It's like $300 or $350 a pop. And when I'm charging for a tummy tuck, that's not an add-on. I don't like ask a patient like, hey, do you want to be comfortable?
Yeah.
Would you like to be comfortable for a couple of days? It's in there. Yeah. It's on. It's happening. Totally. It's all part of the process because I don't know who when you're paying good money, would be like, I'd rather just hurt, save a couple $100.
Yeah. Well, it's like, do you want to have a good looking scar or do you want to have less pain? Because you're going to have to choose. It's one or the other. You can't have both because they both cost extra. It's like one of the dentists I went to, they're awesome, but they hand you this menu. It's like a la carte. It's like, what do you want today? Complimentary, like warm towel, a drink, numbing medication, laughing gas. I was like, wait, what? I have to like pick? And you can get the other things, you just got to pay extra, So like they include one of them. You got to check the rest if you want to get it. I'm like, I don't.
And is there a tip at the bottom? It's like tip 15%.
Yeah. What'd you think of our service? Just
how's your service? 5 stars. Yeah. Oh my God, that is terrible. Yeah. No, I just it's built into it. I feel like if you're not using it, it seems crazy to me.
Yeah.
The mix that I use, I don't know. Do you mix your Exparol with anything?
Yeah, I do. I mix it with Marcaine actually. So I dilute it 10 to 10, or like in half essentially, so I can add it along the full. Like I put in the rectus sheath, and I do even try to do a little bit of a tap block laterally too. But what do you do?
Yeah, so I took a mix from. He's retired now, but it was a plastic surgeon. It was in Portland. He had a Exparol Marcaine mix. He puts Toradol in it.
Wow.
And clonidine, which clonidine is not much in the plastic surgery literature, but for the anesthesia literature, there's good data that suggests that it increases the length of nerve blocks. So I have that in there, and then actually dilute it out with like 100 to 150 of saline, and then have epi in there as well.
Oh, you do it super dilute then.
Yeah.
That's
so
dilute.
So I've got like when it's all said and done, it's like 250 in total, and I hit like the entire abdomen, like rib cage to the pelvis, poke, all the way through rectus sheath, and then a good like 20 to 30 cc's tap block on both sides.
Oh, awesome.
Yeah. So
you'll have to send me that mix. That sounds awesome, dude. I'd like to try that.
Yeah, happy to. Yeah, but I just
cool.
He was a senior surgeon at the time when I was just getting started. I was like, this seems good. Started using it. I was like really, really happy with the results.
That's awesome. Yeah, I've heard of some surgeons putting even in tumescent fluid. I don't know how I feel about that. Like really like super dilute throughout, I don't know what effect that actually has. I've tried it in breast tissue and things before. And even in the pec muscle, I wasn't super impressed by it in the breast at least. So I kind of backed off that. I felt like that wasn't as effective, but I really think for the tummy tuck stuff, oh my gosh, it's amazing.
Well, it's because the tummy is so painful. I feel like you have a lot of benefit there versus the breast. If you're really good, even with just lidocaine, Marcaine mixes, you get good coverage, and then it's not so painful. So you don't need that like extra benefit, but I guess it wouldn't hurt anything.
Okay. So along injectable medications and IV meds, I think we should talk about TXA.
It's everywhere.
Because it's everywhere right now.
It's everywhere now. Plastic surgery, TXA for everyone,
right?
In everything.
I can't ever say it right. Tranexamic acid. Did I say it right?
Yes.
TXA.
Yeah.
So I think originally it was like used in like ICU. I remember using the ICU like on these like sick patients for other things, but
trauma.
Yeah,
like
trauma.
Big traumas.
Totally, right? They're like bleeding out and stuff. So using it on these patients. So I think it's really, like you said, it's kind of really come into the plastic space, whether it's in rhinoplasties, face, but even like I put a TXA in my liposuction, like in tumescent fluid, very dilute, and I limit how much I put in the first couple of bags, but then people are doing IV. But I think there's almost been a little bit of a pendulum swing because now, like you look at there's some studies coming out, even like case reports and things of patients with like skin flap necrosis on like facelifts. And some issues, and they are attributing that to possibly TXA. I've had a couple of surgeons I've talked to, even tummy tucks. They said they've noticed some necrosis and flaps they've never had. So, what are your thoughts on that, dude? Or what do you think's going on there?
Yeah, I guess my question for those folks who have been having flap necrosis: are they doing IV or are they doing tumescent?
My understanding was it was tumescent. Because and like for me, I've never seen that, but and I've literally used TXA for a couple of years now, and I have not had that issue. But I don't know, like I think there's some other variables that maybe we don't know about, right? But I've heard of this stuff happening, and so like I think we always just reassess what we're doing and make sure we're doing what's safest for patients.
Well, I think this is like a super common thing for plastic surgery because we have the ability to latch onto something interesting and then like take it forward super quick because in the cash pay world, we don't have to ask anything from anybody. Just like make it happen. This seems like a great idea. Let's give it a shot. And then everybody's doing it for everything. And then we find out, oh, there's a downside to this. Maybe we should back off a touch. And then we start to suss out like who is good for and kind of who it's not. For me, I don't use intumescent fluid because the data looking at like skin flap necrosis makes me worried that having it in the sub-Q space may increase the chance of having necrosis. So I just do IV at the beginning of the cases. And I do that not only for like tummies and for, breast augmentations and those types of cosmetic cases. I'm also using them for top surgery, my insurance breast reductions, any of these cases where I have like a large potential space where it would be like a devastating complication to have a ton of blood go into it. Yeah. For all of them, before cut, TXA at the beginning. Yeah. And then I don't redose them. I know some people redose. Yeah. I don't know what the literature is going to be for that. I think if I had to say there's a difference, I would say that drain outputs for patients and how bloody the drain output seems to be better, but I don't have I don't have a quantitative way. I'm not looking at their, what the blood loss was or what their hemoglobin change was for pre-op to post-op. So I feel like it has been helpful, not dramatically so, but I haven't used it for any tumescent fluid stuff.
Yeah. I've been doing it, and Dr. Ben Tele, he's wrote actually one of the papers on this, and I think he actually talks specifically what he found. And so he has like a certain concentration. So if you look at those little vials, it's like 1,000 milligrams, it's like 10 mLs.
Yeah, it's 1 gram.
Yeah, 1 gram. So essentially he's saying, I think you can only do like even half that max. And so he's kind of said that there is, I think, a threshold, and so like for me, like I'll do that and I super dilute it and only do it on the back lipo and a little bit on the front. And I guess I haven't had any issues, but yeah, there's always these things I think we always got to be careful as plastic surgeons. Cause like you said, we love to latch onto things, take it as far as we can, maybe push the envelope a little bit. And, that's innovation, right? I mean, no one would have done a kidney transplant had you not pushed the envelope a little bit, right? Yeah. So, all these types of face transplants, hand transplants, everything we do in plastic surgery, there has to be some of that, but it has to be, I think, also done safely and carefully. Yeah,
just finding a better way to do things. And the only way to do that is to try new things within reason. Yeah. I think the thing that's, surprising with TXA is everybody says like, well, you have all these benefits and there's like no downsides and like no increase in blood clots. You're like, I don't know how that could be like possible physiologically, but I'm sure we're going to find out there's a certain subset of people that it's just not great for. We just don't know who that is yet.
Totally.
But for now, it's the Wild West of TXA for plastic surgery.
It really is. Yeah. I know. I'm being more and more conservative on it. I'm doing it less. But okay. So along the lines of clotting, you brought up clotting. I'm pretty aggressive with, I would say, anticoagulation on patients. I would personally rather have a little more bleeding than a lot of clotting. I don't have higher rates of hematomas. I knock on wood, don't remember the last time I had a hematoma I had to treat, but I do heparin sub-Q at the beginning of every tummy tuck case. I used to do Lovenox and then get Celebrex, and I noticed they actually, their drains are really bloody. So I went to heparin, and then any patient that has like a higher risk, like a Caprini risk 5 or higher, I'll do Lovenox for even a week or longer. I'm just curious. I'd love to know, like, what is your practice? Do you do any anticoagulation? What's your kind of threshold?
Yeah, I mean, not standard. Like, I don't do it for every single patient. For people who are like the lower risk categories, for higher risk categories, absolutely no doubt about that. I think for me, pain control and I like harp on people for ambulation is my big things. But yeah, I don't consistently do it for every single patient.
Cool. Yeah, I think it's something I started doing. I mean, probably 3-4 years now that I've been doing it. Like I said, I don't think I definitely agree with the literature. It does not increase your risk of hematomas. I would say out of over 3,000 patients in the last few years, I've had 3 patients with blood clots. So the rates are very low. And the 3 that had it, 2 of them had a history of blood clots. We actually already had them on profile. They were already on Lovenox, like literally. Wow. They still got it, and they were fine.
It's happening.
Yeah. And then they're still fine. Yeah. I'm like, what are we going to do? And then one patient had actually a small PE, and it turns out she found out she had family history that no one, like, when she starts asking her family, oh yeah, mom had a blood clot. Dad, I'm like, wait, what? You didn't tell us this stuff, right? So, and she had a paniculectomy. She didn't even have a tummy tuck.
Oh, wow.
So I think, there's going to be, you operate enough, you're going to have some of those things happen. And so I think it's just up to us to make sure we're as safe as possible. Like I said, assessing like patient safety risk, all that stuff.
Yeah. No, I think in residency, between all of the attendings, I saw a couple of PEs, people rush in, shortness of breath, like the real deal, not just like teeny tiny ones. But I got to say, the people who seem to get those the most were the surgeons who had the patients who are like super duper sore, who are completely incapable of like getting up and moving. So for me, I'm like, okay, well, if they're comfy and they can get up 7 times a day to do something, it's like, that's really, we know that that's the most important marker for getting blood clots. It's like being a total slug and being unable to get up because you're hurting is the big one. Yeah. And I always tell people, it's like, you're going to have help, right? And if you have help around the house, what you're not going to do is you're not going to ask them to get you a glass of water. Yeah. You're going to ask them to help you go get a glass of water, because getting that glass of water or going to get a snack or going to go pee, that's a life-saving walk. Totally. Like, get up, moving around, just super important. So I really bug people on that. Yeah. And when I have staff call them the next day and make sure it's like, you've been up and moving, right? You've been up and moving. Same thing when I'm texting them, check up on them. It's like, how many times you've been up today?
Totally. Super important. And honestly, the patients, I think, that do the best, like you said, they're ones that are up and mobile. You see that in ICU literature where it's like, even these cardiac patients, they have them up, they're on ventilators and they're walking the units, like, what the heck? It's like the RT is like walking them, they got a therapist, physical therapist. Those patients do the best and get out quickly. And, you kind of brought this up when you had your surgery. You're back operating, a couple days later. I had an ACL surgery, and same thing, like 2-3 days later, I had a brace on, but I was operating, and I never did any physical therapy. My orthopedic surgeon's like, oh, you're fine. And it's just because I was moving right away. I didn't let
you can't build scar tissue if you're moving the entire time.
I wasn't weight bearing on it, but I was moving stuff, But so I think definitely you got to practice what you preach, but also like it's super important and helping patients understand that. And I think that's on us as, our practice, our nurses, our team, like educating patients on that.
Yeah.
So I actually have a question about lipofoam. What your thoughts are on it? How long did you wear it? Because my patients, it's definitely love-hate relationship. More hate than love.
They all hate it.
Right? And I'm about to experience it. So I'm trying to gauge from you because
it is constricting. And when patients say, I feel like my skin isn't breathing well, like that is, it's a weird thing to think. You're like, well, you don't breathe through your skin. Like just physiology. I guess you do like a little, but it is a very weird feeling. And I feel like the lipofoam or Rest-On that is foam all the way through without the silicone stickiness, I feel like that breathes a little bit better. But that stick-on stuff, while it does stay put, it just feels uncomfortable and weird. And it just like feels like
almost
sticky,
claustrophobic,
sweaty.
I bet.
Yeah. And it's when you're wearing just the compression garment and it's, that netted fabric and like moisture can move like that doesn't feel so bad, but the lipofoam itself is weird. And I really did not care for it after just like 2 to 3 days. And I think the vast majority of my patients feel that way. I have the rare patient who like, I want to wear all the compression stuff all the time because I think they're just like excited about getting the best possible result.
Totally.
But I feel like people just don't dig it.
Yeah.
But I try to tell people, like, if you can keep the foam on for the first week, great. If they are at a visit at a week and they don't complain about it in any way, I will just allow them to continue to wear it for another week and try to get 2 out of it. But then past that, I'm like, yeah, you can toss that. It's fine.
Oh, dude, I make them do 6 weeks. Don't tell my patients you're doing 2 weeks. Yeah. Don't tell them 2. Don't tell them 2, man. There's going to be a revolution up in here.
They're like, what? 6 weeks?
Oh, but I don't have the Rest-On, like the adhesive one. Most cases, I don't.
Yeah.
So they can take it off. And it's typically, I have them wrap it around unless we're compressing specific, areas. But
yeah, if it's without the sticky, I feel like without the sticky, it's more comfortable and people will tolerate it longer. But I'm going to be interested to see what your feelings are after you experience it. You're going to be like 2 weeks for everybody.
Yep.
Just going to change it up.
Probably
2 weeks.
They'll be so happy.
You're like, why have I been doing this to people?
So
that is brutal.
I have a patient. She like hated it so bad at the 6-week mark. She took all the lipofoams, because they're all kind of nasty at that point, and she put them in a bin. And she wanted to do an Instagram, like a TikTok, and show herself burning it. She was so mad.
Oh,
she went to burn it. It wouldn't even burn. Like it wouldn't even light on fire. She's like, this stuff is like of the devil. She's like, I can't even get rid of it.
It's unkillable.
Yeah.
I was like, even if you could set it on fire, the fumes, I mean, that is definitely like so synthetic, right?
Yeah.
Whatever's coming off of that, you better be wearing like a full blown gas mask. It would definitely kill you.
Yeah,
I can't imagine it'd be good for your lungs.
For sure. But it doesn't burn, so you don't have to worry about it.
Yeah, apparently. Yeah. Like gasoline, maybe. You probably need an accelerant. This is what it's going to take. But yeah, I'm curious to see what your thoughts are after experiencing yourself. But yeah, the stick-on stuff, it is nice that it stays. Like you pop it on and then it's really easy to put a binder on. It's easy to put a compression garment on, but it does feel very confining. Super annoying.
The things we do, I think of like everything that surrounds that, lymphatic drainage, lymphatic therapy, lymphatic massage, whatever you want to call it, all of that. Plus the foams, plus the garments. And now you add in like elements of like summer, it's hot, it's humid, some places like, oh my gosh, but we do it, like you said, why do we do this? We want the best results, right? This is all we know. Like, I don't know. I mean, obviously if there's better materials, we'd use them, I think. But
yeah,
it seems to work.
Yeah, I think with the compression garments, I feel like that's one of the major reasons that you see like a dip during the summer. It's like no one wants to be in a huge recovery when it's like pool season. Like I absolutely get that. But here, it gets pretty darn hot sometimes. It'll get like into the hundreds, and it's not super humid. It's not Alabama, but being in a compression garment that you can't get out of when it's 100 and you're in Pacific Northwest and there's plenty of places that don't have AC has got to be like just absolute, complete, total torture. Like I can't imagine. I can't imagine. It'd be horrible.
Totally. When I first started doing tummy tucks, a lot of people would come in asking, and this is just my personal thing, and I don't know what you do, but I would do mini tummy tucks, and I think there are some patients that are good candidates for a mini. But sometimes when we're doing those, we have to float the belly button, right? And we're always trying to gauge, like, okay, is this going to go down too far? Is this, in our zone of like looks normal, or is it going to look kind of weird, right? And so that's always an assessment I think we have to make. But the more I kind of do more tummy tucks, I just kind of steered away from those. I just feel like I wasn't getting great results that I could get with a standard tummy tuck. And so for me, a standard tummy tuck would be going around the belly button on an outer level of the skin, diastasis repair the whole way down, right? Pulling the skin. I think I get better consistent results for me. So this patient that came to me had been to another plastic surgeon and had at that point a mini tummy tuck with the belly button float, a revision to that, a conversion to a full tummy tuck with lipo and all these other things. So by the time she came to me, she was like a tummy tuck cripple. I don't know if you want to call it that. Her scar was very straight across, like all the way around, and then dipped down because it was so low that it, kind of hooked down by the thighs, that lateral thigh tension pulling it down. Couldn't really do anything about that. The skin was super tight. She had been lipoed a few times, so there was literally skin on muscle fascia. So there's no, it's just flat, right? And then her belly button, because it had been floated and then cut around the surface and moved down, it was off-centered, like literally off-centered, and sitting about 2.5 centimeters from her horizontal scar at a level barely above her pubic area. So the belly button was just and it was flat. It just looked like a stuck-on piece of skin, no definition. And then on top of that, there was like scar tissue around it. There was like a bulge because they had left some fat to try and give it some depth, And then there was a potential hernia. So this case, I was just like, oh my gosh, like I've never seen anything like this.
This is one of the ones where I'm like, I want to take pictures and I want to think about it tonight. Then I'll call you tomorrow with like my game plan.
I literally reached out to Dr. Hoyos, Alfredo Hoyos, who's a world-renowned plastic surgeon out of Colombia. Who's now,
and the belly button guru of like the world.
Yes. I mean, he literally removes your belly button to make his own because they look better.
It's better. Yeah. It's better than what God gave you.
Yeah. So, and he is the nicest human. I reached out to him. I asked the patient for permission. Can I talk to a surgeon about this? And I had a plan. I gave her my plan. I said, look, I think we need to do this in 2 stages. I think we need to give you some depth to your abdomen first. And we need to get rid of your belly button. And this is going to sound weird, but we got to cut it out. Gone. And we're going to make that scar as thin as possible so it looks like a little vertical scar. Now it's a little off-centered, but we'll do that. We'll laser it. We'll treat it so you can't see that, right? And then I will fat graft you. So I told her I would fat graft her all along her rectus abdominis muscles, all down the lower area to start to build up some thickness because she had no depth. And I was telling her if we just cut some skin right now and did that, it would just look like you had this flat belly button. So I'm like, you need depth. And so I talked to Dr. Hoyos, sent him photos. He's like, yeah, I think your plan's great. I would do that. And I told him I wanted to use his H-wing technique. And he said, that's great. Here's some videos, super nice. So we did the first stage, took out the belly button. Just the act of me cutting out the belly button and trying to get that skin, that thickness, scar tissue out, that skin almost like necrosed. Like the blood flow was so bad that first surgery, it was like pale. I was like, oh my gosh, like what did I do, And luckily she was fine. The fat stayed really well. And then about 6 months later, we came back, fat grafted her again. But when I went to cut...
Oh, second round.
Second round, yeah. She retained fat pretty well the first round, but she needed, that's how much she needed. She just had nothing there. So I came back, grafted it again, and then I cut the H-wing belly button out, and it looks so good. She's so happy.
Must be amped.
Yeah. And that, it's like one of those cases where you do that and it's rewarding for you as a surgeon because you're like, man, like I went into this, like I've never seen this. I know some tools. I know some people. I think I can put a good plan together. And then to have that patient trust you, like, let's do this, like.
You're like, I have never done this before, but here's the plan that I've enacted. And brought together.
So yeah, it worked out. She's feeling great and looking good. Yeah, man. How about you, dude? So how about let's hear yours.
Well, for your story, I think this is actually super important. I think this is something that's like one of the amazing things about plastic surgery that people don't necessarily know is that plastic surgery, we don't necessarily learn techniques, right? It's like how you learn to take out an appendix. Like I have learned how to take out an appendix and I will just take them out like this.
That could be a factory
forevermore. But it's all about figuring out what your goals are, knowing what the tools and the arsenal is, and then figuring out an effective game plan to make that happen. So you can come from a totally like unknown, patient with very specific goals and like get them there with a plan that is like maybe never been enacted before, but you can come up with something that's going to make sense and actually get you there, which is like so unbelievably special to like our specialty. And I love that when somebody comes in with just like a weird problem, I'm like, wow, that is totally something that I have never seen before. But based on my knowledge of plastic surgery, it's like, I'm going to come up with something that's going to work. And that's just, it's fun.
It really is.
Scary. Super scary, but it's fun.
But you trust those fundamentals that you learned, those principles, those tools that you have. And I think, you can definitely execute, and
the reconstructive ladder. As we all learn in residency.
Yeah, it applies even through, aesthetic cosmetic surgery for sure.
Yeah.
Let's hear yours, man.
I'll give you my story. So I had a patient come in. She had already had surgery with another surgeon from another state. She was actually from Portland, but went to another state to have surgery because one of her friends recommended this other surgeon. She came to me because she had concerns about how that first stage had gone, and she was planning another surgery with the surgeon. She was kind of like not sure whether she was going back, and she wanted to get like a second opinion of like a surgery she's already had, which is weird to me. Like anytime I have somebody come for a second opinion, they're like, a second opinion to like fix something. She's like, I want you to give me your opinion of the surgery I had of like, did this all make sense? The story seems wild to me. Is this like how plastic surgery normally works? So she had surgery in Washington, so it wasn't that far. She had like driven up there, and she was like, I had a circumferential lower body lift and 360 lipo, and then she also had like upper back liposuction. And just standing as she's talking to me, I'm like, she's not a candidate for the surgery she's just stated that she's already had. I mean, her BMI was high 40s at the time, and she said that they had taken off like 30 or 40 pounds of tissue during that surgery, so she was probably in the 50s for her BMI when she had that surgery.
So much tissue.
Yeah, it was wild. So she said that there seemed to be issues with the surgery. The surgery went longer than anticipated. She said the surgery was like 8 or 9 hours.
Jeez.
Like it was a long one. And she said the reason that the surgery was so long is that they encountered a hernia during the surgery. And I was like, okay, found a hernia during the surgery. So she said the surgery was incredibly long. And then that evening she went to an Airbnb to recover. And I was like, she went to an Airbnb. I was like, were you with like your family at this Airbnb? And she was like, no, the doctor and his like staff came to the Airbnb to like check on me. It was like their version,
like a recovery house or something.
Yeah, like 23-hour ops, but in an Airbnb where it's like they're checking on her. And she said that during her time there, when she was kind of like high on medications, that the staff member who was with the doctor said that she should be very excited about her upcoming breast surgery because the doctor had done her surgery and actually like flashed her while she was like high. It's like post-ups day 0 and all this kind of stuff. So I was like, I mean, surgery was very long. That seems kind of wild to me. And she said that while the surgery was super long, she actually lost vision partially.
What?
And this is actually the second,
like after surgery.
Yeah, because like during surgery, like afterwards, so she partially lost vision. And this is actually the second time I've heard a patient like lose either partial or like complete vision from having a surgery that took like entirely longer than it should have been. Yep. And apparently it's either due to prone positioning, due to pressure, or just having low blood pressure during that time. And she was far enough from surgery that the ophthalmologist said that she was not going to regain this. Geez. Like it was just like partial like vision loss. And I'm like, oh my God, you're like going to go back to this person. You've like lost part of your vision. So then she showed me the picture that the doctor had shown her of the hernia, and the hernia sac was like enormous, like this gigantic sac, and the guy's like holding it up with like somebody else who's there, and it's this huge hernia. I was like, the hernia is like the size of like a grapefruit or something, and they had no idea that it was there, which seems like wild to me. But apparently, this is the reason why the surgery took so long, and that she was like partially blinded. And what I'm shocked about is that otherwise she like recovered pretty like uneventful. Like she didn't get like blood collection, fluid collection. She didn't have breakdown. I'm like, that is all like very impressive to me that none of that happened. But then after this whole thing, she was like, the thing that concerns me the most is that he found this massive hernia that we didn't know that we had, which seems shocking to me, but that he didn't call in somebody to fix it with him. Like, do you think that he was qualified to do the hernia repair? And I'm like, I don't know. Right. It's like, I don't know the guy's name. I've never heard of him. Yeah. So I was like, let me bust out my phone. Let me take a look. And I look at it, and he is board certified in cosmetic surgery. He's a general surgeon. I was like,
maybe he's qualified.
I was like, that's
what he should be doing.
I was like, that was the part that he was the most qualified for.
Yeah, not the rest of it. Not the rest of it.
Because the rest of it, I'm like, the rest of it's all wild to me. But the hernia repair apparently went totally fine. So she was like, after telling me this whole story, she was like, do you think I should go back to that person? I was like, I mean, he performed a surgery that shouldn't have been offered to you. Out of the gate, totally, like I would say, completely unsafe given her size. Yeah. Surgery took entirely too long, partially blinded you, found a massive hernia that we didn't know existed.
Yeah, just a poor workup.
I would say probably don't go back to him. Like I wouldn't. It's like, I don't care how cheap it is. I don't think I would return. But the whole thing was just like wild to me, especially the doctor at Airbnb. I was like, I don't know. Have you ever made house calls? It's like, I haven't gone to anyone's house. I haven't gone to like an Airbnb. I'm not going to like a Verbo.
So I did go one time. It was on Christmas Day. It's because I had just started my new practice in 2019. Different situation. It wasn't an Airbnb. They live down the street from me. It's kind of fun.
Okay.
So, but yes.
Like same neighborhood.
Yeah, same neighborhood. But yeah, so it was Christmas Eve. We did the surgery. I had just opened my practice, and I was like, we got to make sure we can pay the bills, right? And pay the staff for the holidays. So we had just like one case on Christmas Eve, did it. And then I'm like, I always see him post-op day one. So post-op day one was Christmas Day. But it's cool. I'm like, it's actually her in-laws lived down the street from our house. And so I was like, if you're cool, my wife and I will come over because I want to chaperone. Just checked on her and she did great.
Oh yeah.
So
that's smart.
Yeah, it was fine. That's the only house call I've made, but not that I wouldn't if I had to, but yeah, I don't usually do Airbnb type stuff.
Yeah, that was a new one to me.
Wow.
So on Christmas Day, do you bring him a gift or they bring you a gift? What was the gift situation?
I think I brought him a gift of ABDs and gauze, extra gauze.
To deal with errant drainage.
Yeah. No, we still laugh about it to this day, actually, because she's my patient. But yeah, it's funny.
Yeah. I mean, the flexibility, I mean, it's just nice to know that it's like you're willing to do it. I remember Emily told us a story that she had like a patient that she couldn't track down who like couldn't come in. So she like packed up her bags and like drove to her house to like go see her and get post-operative photographs and all that. It's just like,
well, especially in our boards collection, you're like, you have to have 3 months worth of photos.
You better have that photo.
Better have it. Yeah. I had a patient during my boards, because we obviously studied together. But I could not get him to come in or even send a photo. I couldn't get a hold of this guy, and he had shot himself in the hand with a gun by accident. So I had repaired a bunch of tendons.
What, not on purpose?
Yeah, no, not on purpose. He was like cleaning his gun, or I don't know. So I fixed it, all that stuff. Anyway, I needed follow-up photos of his hand, and I could not get a hold of dude. So I like I found his wife somehow because she followed me on Instagram. I like messaged her. I was like, hey, I need to talk to your husband. I couldn't obviously say what it was. I was like,
just slid into the DMs.
Yeah, I literally slid into her DMs. I'm like, I need to talk to your husband. I'm like, I tried calling him and not get a hold of him. So she said, okay. And she's nice. And then he ended up calling, and he just sent in like a shot of his hand, literally just like off his iPhone selfie. Yeah. That's it. That's what I turned in.
Just send me one picture of your hand.
That's all the board. That's all they needed. It was fine.
Oh my God, that's so funny. Yeah, I thankfully didn't have anybody that had like troubles with tracking down during time. That time is so stressful. Thank God that we don't have to do that anymore.
Yeah, my associate Brian Pfeiffer, Dr. Pfeiffer, he's going through it right now. He submitted everything, and just the stress. I remember that of just being like, okay, like what if I don't pass? I got to collect again. Like you're just kind of that limbo state right now. Between now and like the fall. Until the exam, oh man. And then finding out around, the holidays in December, if you passed or not, I'm like, ugh.
I was going to say our junior partner is going through the process as well. So we can get my junior partner, your junior partner, they can get together and then they can have their own WhatsApp group.
Oh, nice.
For life.
All right. So everyone, thank you so much for tuning in to Plastic Surgery, A Cut Above. I'm Dr. Jerry Chittister. This is my awesome compadre, Dr. Sean McNabb. There you go. I don't know if I said, you should say it or I'll say it. I'll let you say your name.
Yeah. I guess maybe I can say my own name.
That's good. But yeah, thank you guys for tuning in. We'll be doing more and more episodes, and maybe someday we'll have some guest speakers. I don't know. What do you think?
Yeah. Oh no, I think so. Cool. I think it'd be fun.